Hi, and welcome to the presentation regarding research capacity building, and where I will be sharing my experiences from Sub-Saharan Africa. I think for all of you who are working in public health or you are studying public health, you are familiar with this slide where people would think what your friends think you are doing, what your parents think you are doing, what the society, your neighbors, they think you are doing, and what your boss is thinking that you are doing, and what you think you are doing as a hero, but in reality, well, you are doing all sorts of things that every day there are different things happening around you, especially in global health. So I think all of you now are familiar with the SDGs. So I will only focus in this presentation on the SDG number 17, the partnerships for the goals. Because although we are familiar with this picture showing one person carrying a big stone, but in reality we know that one person cannot do it. So it takes, as they say, it takes a village to raise a child. So the partnership for the goals, it's the SDG 17.9, and it says here, I will not read the whole text, but I will emphasize on these concepts or notions that underlined: to enhance an international support, to implement effective and targeted capacity building, and to support national plans through north-south, south-south, and triangular cooperation. So it requires a lot of efforts, plus to make it sustainable. It requires a lot of efforts, and this cannot be done through one stakeholder. It requires really a strong partnership. This triangle here, I will take you through it. In the bottom of the triangle, you have the foundation and interest in research when you are doing your capacity building. Then you have research skills support. Then you have to provide a graduate scholarship for master's degree, and then you have a PhD scholarships. So the vision is that you need to build this capacity for the staff to start by, for example, my work was including introduction to research seminars, doing online courses in research and global health, and doing journal clubs. So the staff will be able to understand how to read the journal clubs. Then in the research skills, we have statistical training workshops and writing workshops. So the bottom here is about how you can be systematically digesting knowledge and turning it into action in your practice. On the top, how you can do statistical analysis and how can you also start producing knowledge. It can be through operational research, it can be through research projects. And then for staff who are interested in doing masters in epidemiology or in public health, and they can want to publish as well. And on the top, we have the PhD scholarships. So the support can be in one of these capacities. Ideally, you want people to enter here in this triangle and go all the way up. So in this way, when you have people starting to practice how to become knowledge consumers, and then they will be having the introduction to research. So one of the projects I worked on them, which I will be talking about it later in this presentation, is called Series of Epidemiology Implementation and Operational Research, the senior course. And then the second one would be the expected outcome is that they are active in publishing, so they can have their master's degree, or if they're not interested in going for a master's degree, they want to publish so that they can have an evidence from their work. Also, they can practice here how they can publish in internationally peer-reviewed scientific journals. Eventually, this is what we want to reach. We want to have these people who finish from here to here, from the left to the right-hand side, that they become more active in capacity building. So what will happen is that they become trainers, and then we will have more human resources entering into this triangular model, we can call it, and then to become trained. So then to have a sustainable model in the context or the country where we are doing capacity building. Now I want to switch gears to talk about three examples from Zimbabwe, from Rwanda, and from Central African Republic. I have used here the global index ranking to show each country where they are standing and unfortunately Central African Republic is in the bottom of the index. Then we have Rwanda, then we have Zimbabwe. Zimbabwe, as you all know, has a long history of economic inflation now for a couple of years. That also this led to, we can call it the bleeding of human resources, that out-migration of the staff, healthcare staff, nurses, doctors, leaving Zimbabwe because of the hardship in Zimbabwe to other places, and this created a big gap in human resources inside the country. Also on the top of it, we have the layer of the HIV epidemic, and now, which was among the adults, and now it is an emerging problem as well among the pediatrics or the children. My work with Zimbabwe has started since my PhD training back in 2006, so now it has been almost 12 years on and off, also with my former mentor from Stanford University, and with collaborators from the Biomedical Research and Training Institute in Zimbabwe. So the training started in form of a weekly, 1 week per year or 2 weeks per year of intensive training, introduction to research methods, and regarding low-cost diagnostic HIV, and also self-diagnostic models for cervical cancer, plus to mentor students that are enrolled at University of Zimbabwe doing their master thesis or their PhD thesis projects. So the idea was started that to have north-south collaboration, and here I made this kind of the triangle showing it starts from high intensity from north-south to reduce it, and then to build this, to have south-south collaboration. Then to have local capacity building each other. So you train the trainer, and then the trainer will train local trainers, and this is how it will go. This is an example from 2 years ago from this 1 week intensive training in Zimbabwe, and these are my colleagues, and here in the picture you see also colleagues from Zimbabwe who became senior researchers, and they are also training students locally. Now in Rwanda, Rwanda is considered one of the most condensed countries in sub-Saharan Africa. It has no access to the sea, so it is a landlocked country. And the idea of Rwanda to become a land-linked country according to their 2020 strategic plan. So Rwanda now has also a problem, an emerging problem for the non-communicable diseases. Partners in Health is an international NGO from the US, originally has been operating in Rwanda for over 14 years. So I worked with them and with the Harvard Medical School 2 years ago, and they are supporting 3 rural district hospitals. In the in the eastern part there is Rwanda here, and then Kirehe. And then in the northwest there is Butaro, where there is an oncology excellence center for treatment. I was based mainly here in Rwanda, and I used to travel from time to time to Kirehe and Butaro, but my base was here in Rwanda. So the research capacity building was in form of training staff, regardless of their disciplines, and the staff would come from Partners in Health, or the Ministry of Health, or the Rwandan Biomedical Center, which is quote unquote, it's like the Rwanda CDC, you can call it. The first platform that was available for training was the Introduction to Research course. So it was a 10 weeks course where we meet weekly, and every week we have 4 hours of class-based teaching, and they will have 2 homeworks per week, which is a journal club paper, and they will have also a test, pre-test and post-test knowledge. Here in the picture you can see the book that was used. It's a booklet that was built in-house. We made it, and this is the director of the former director of the Rwanda Hospital, where we had 15 participants. Here you can see the picture of the team, and this here on the top right hand side is during the break. At the beginning of this course, it wasn't easy for the staff regarding the time, if they have time commitment at the hospital, if they get busy. So we really needed to ask the hospital for their support, that the hospital leadership, they need to endorse the participation of the staff. So this was extremely important, that the hospital shows and endorses the time dedicated for the staff, so they don't miss these weekly meetings. So this is very important in capacity building. There are always emergencies happening. There is always a need for the staff to be there, and they are tired. But it's very important to make sure that they have this time, protected time, for their participation in these sessions. So at the beginning, it wasn't easy. We had to make a lot of efforts to have this protected time for them. Also, the selection process needed to be inclusive for the hospital, for us, the team who have arranged the course, and for the different departments where the staff have applied. So there was a sort of a grid to assess the applicants. So applicants were also, when they were selected in an objective way as well. So it's a long process. Eventually, you can see during the journal clubs, the improvement and the transformation that happened to the staff in terms of reading the papers, in terms of their contribution, and the discussion in the classroom. The second platform was a series of epidemiology implementation and operational research. It's called the senior training. So here we split the class participants in terms of, we have 8 participants and there is a mentor. The mentor role is like a supervisor, and the expected outcome here is a manuscript per project. And every project will have 2 participants. The duration of this course was 10 months, and we meet every 3rd month for 1 week, intensive week. So what will happen is that there will be 1 to 2 content experts, and there will be a previous trainee from the previous cohort who will also come and join in this training. Then there is 1 research assistant to also support. So when the participants, they go through this course, the first week will be regarding introduction to research and literature review and project proposal. And then they will start working on this, and then the second week there will be intensive training on data analysis, where they need to produce their own tables. And then they will start writing the paper results and discussion, and then the 3rd week to wrap up the paper together and then to submit. The 3rd type or platform, it is face-to-face training. There are certain staff that they have some project happening and they need help. Their time might not allow them to enter into the other 2 platforms. There is something they need directly for their work, and then the support will be provided to them in the form of face-to-face training. So this is my colleague and friend, Dr. Ruzingiza. He is a pediatric cardiologist in Rwanda, and we work together on his paper showing the surgery outcome for rheumatic heart disease in 3 rural districts in hospitals in Rwanda. The paper has been already published in the Heart journal, and it was a fantastic experience because he has a very busy time. There are only 2 pediatric cardiologists in Rwanda, so sometimes we have to meet early morning, 6:30 a.m. before he goes to the hospital. We will be meeting on the weekend, so it's very important in this setting is that not only about the training and the work itself, but also it's about the friendship. There is a cause that is happening in real life, that these are for in an international context. Sometimes we look at the data as numbers, but these data, they represent patients and they represent persons and lives. And this is what I appreciated working in Rwanda, that the staff and the doctors and everyone, they always think of them, these are like their children. And this is very, very important to keep this in mind, that we are working towards an important cause here, and how to contribute to the betterment of humanity. So it's very important when we are doing this training, either face-to-face or in groups, that we keep this in mind. Also, there is, in the face-to-face training, it can be also working in groups. So these are 2 colleagues that they were interested in knowing the risk factors for loss to follow-up for diabetic patients in 2 rural district hospitals in Rwanda. And here also we have to go into the whole complexity of the clinical records and how to make sense of data collected for clinical purposes, so to be able to use them for research purposes, So it has its own complexity as well. Plus, one staff is based in Rikwavo, the other staff is based in Kirehe. And regarding traveling and their time, to also have protected time for this training. Plus, sometimes there will be emergencies happening. So this type of training is also important and relevant, but also they need to be very patient, because if the staff is busy, there is some emergency happening, this takes over the priority, versus when they have protected time for 1 week, or when they come 1 week, one afternoon per week. It's different because it's the group of people. When you have a group of people, it's easier to negotiate with the hospital. But when you have 1 or 2 people, then it becomes more tricky. So each modality has its own pros and cons, but eventually you make it. This is my colleague and friend that has worked on risk factor for child growth stunting in Rwanda, and it was a national-based study using the demographic health surveys, the DHS. It's publicly available data set, or one of the kind of the big data, you can call them. Here we worked together for almost a year, and also he was engaged in different projects. Also he was traveling, so that was always a challenge, that we make sure that we keep the momentum. Eventually we made it. The paper has been published and presented in the Canadian Global Health Conference. Also, this is the other sad reality of global health. When colleagues from low middle income countries, they get their abstracts accepted in conferences, in international conferences, the sad reality that they don't get visas to go and present their work. So my colleague Alphonse, who you see his picture here, he got his abstract accepted in Canada, and of course to apply for a visa it wasn't easy. He needed there is no embassy of Canada in Rwanda, so he needed, if I remember well, to send his papers to Uganda, and it was the complexity of the mail or DHL. Plus, he didn't get his visa accepted. So that was then I had to go and present on his behalf. But also when I was in the conference and I didn't know how to explain to them, then they told me about also other colleagues from other countries that also they couldn't make it for the same purpose. And I think this is also something that is very important to keep in mind, and to try whenever there is a chance to explain to the embassies that they need to do something about this problem. Otherwise, we are talking here about inequity in global health, and this is not encouraging at all colleagues to contribute to the global health knowledge if they feel that, they face these challenges, that they work hard on their work, and he is the first author on his paper, and he doesn't get the chance to travel and present. And in fact, we had budget even for this project that he could travel. He got also funded to travel, but he didn't get the visa. So I think we have still way to go to be able to build this international capacity, also not in low middle income countries, but also in high income countries, the capacity of being mindful that colleagues need to have this chance, and it's their right as well. Now I will switch gears to Central African Republic. The life expectancy in CAR, so during the presentation I'll refer to Central African Republic as CAR or CAR, I'll use CAR. Life expectancy is 51. Under 5 mortality rate is quite high, 13%. And immunization is a challenge. For example, measles immunization is less than 50%. This project was done with Doctors Without Borders, MSF, in collaboration with the World Health Organization in Lyon and the Ministry of Health of CAR and the WHO office of CAR as well. It was done in a province called Montberry-Cadéi. This area size of Montberry-Cadéi is equivalent to the area size of Belgium. The objective of this project was to improve the weekly public health sentinel surveillance in Montberry-Cadéi. Every week, the sentinel surveillance clinics, there are around 21 clinics, they needed to send their weekly reports for 20 diseases, where for each disease they need to show a number of cases and number of deaths. And if there are no cases, they have to write 0 for each case using the WHO 0 policy. So here in this slide, you see on your left-hand side, Monsieur Lazare. He is the focal person for the Ministry of Health Surveillance Office, and now he is retired. And he's carrying the summary of the whole year, where you see for each row the name of the sentinel clinic, and then you have T1, T2. This is in French. It means quarter 1, quarter 2, quarter 3, and then you see in red, it means that they are late. They submitted their paper late, and T, they submitted their papers on time. And empty, it means that no papers were received from them. So he was very careful, very serious about his work to document the summary of the reports. And so you can see that there are many sites that they don't submit anything. Then we don't know actually what type of diseases these sites are having. Now, at the same time, as you most probably know, in sub-Saharan Africa, mobile phone subscribers are increasing. They are everywhere. The mobile phone industry is really big there. And in CAR, the mobile subscribers, they are around 30%. Mobile phones are used for transferring money, for paying bills. Here you can see in the bottom left-hand side of your screen this little kiosk, which is for recharging mobile phones. So people will go and put in their cell phone to recharge, and then they will take a little number, so then when they come back they can show this little ticket and they take back their phone. And then here this kiosk has a solar panel to recharge the mobile phones. The prices are quite cheap for the local market, and it's a big industry. So the idea of this project was to capitalize on what is happening in terms of using mobile phones to optimize the transmission of these weekly public health surveillance reports. So here, this is the overview of the project. On your left-hand side, you can see the pictures that these are the clinics, where each clinic has a smartphone Android, where the app, you can put in the data of the reports, and then the data for every disease will be sent in form of an SMS to a laptop that is used in the office of the Ministry of Health, the focal person of this province. And there is, I don't know if you can see, it's this little black box here. It has a SIM card. So the SIM card will receive all these SMSs, and then we used an open source software to turn these data into a database, and then you can export these database for summary, dashboard, or data sets. So in the pilot, we had in the 21 healthcare centers, you can see here on this map the distribution of these healthcare centers, and then you can see the colors for the type of cell network. So CAR has 3 different cell network companies, and on the northwestern side of the province there is no national coverage there. It is close to the borders of Cameroon. So we have used the 2 cell phones or SIM cards from Nextel, which is a company based in Cameroon. So what happened is that the staff, when they sent their report using the Nextel, we were receiving these SMSs in form of international SMSs. Although physically they are on CAR land, but the SMSs were coming in internationally through Cameroon back to CAR. So here the capacity building or the training needs was technical, to train the staff on how to use these apps, to train the focal person how to use the dashboard system, to have local capacity for also support, training an IT person as well, how to use this technology and how to then install the technology in all these centers, and then how to also introduce this concept to the policymakers and how this can help their work. Also, should they be doing scaling to help them in the costing analysis process, and then to publish an evidence. So this is a quotation from one of the healthcare workers. The project is called PAP in French. So he said, thanks to PAP, we started to understand the value of surveillance to improve community health and prevent diseases. They could really see how this can help their work, and this really started to show us really nice transformation happening on the ground for their work. Here you can see on the left-hand side picture of the battery based on solar panel connected to the mobile phone, and because of the security situation in CAR, we needed to lock the battery in a secure place, and then we had to place the solar panel high up on the ceiling so no one can steal the solar panel at night or during the weekend when the clinic is closed. Here you see the picture of the training of the staff, all these representatives coming in. On the bottom right hand side of your screen you see the PAP officer, Prince, and Mr. Lazar in the training session as well on how to understand the data and to use the dashboard and on the app. Also, we start to see nice transformation happening on a community level. This is one of the clinics on your right hand side of the screen, this picture, where the clinic start to introduce a user fee. It used to be 100% subsidized, then they introduced a user fee. So patients start to avoid going there because they cannot afford to pay the user fee. Now, the local nurse, he felt frustrated that he knows that the community needs his services and the clinic help. So he started to go around in the community and to check on the households and to say hello to them and to see if there is anything happening. So he said, okay, I have now this tool in my hand, and if there is anything happening, if there is any outbreak, I can just send an alert, and to have some help, I need to do something, and I cannot just sit in this clinic and wait. So he shared this nice quote, so I'll read it for you. Patients don't afford to pay user fees in my community, so they travel sometimes to another clinic, or they get sick and stay home instead. I walk now around the community to see if someone is sick, so I can send an alert SMS to MSF PAP to inform them. So you can really see that people start to think outside the box by seeing the power of this tool, and then to see how they can help. And this is also another sweet story that they called this project, the app is called Argus, that this is le pigeon voyageur invisible de PAP, Argus. So it's the invisible pigeon that these SMSs are flying from these different clinics all the way to the laptop. And this really led to nice capacity building in terms of surveillance and in terms of how the ministry can move forward in the midst of these troubles happening in CAR and the limited infrastructure that they have, and how with limited resources, how they can really optimize the help to the community. Finally, I will end my presentation with this nice quote for Picasso, that in terms of capacity building and impact, what you can do, that everything that you can imagine is real. You just by working on it, being persistent, systematic, don't give up, keep doing action, and you will see a progress. But it's very important that don't stop, keep going as much as you can. Thank you very much, and you can always contact me for any questions.